we're going to look at a growing and aging population and how that is impacting the healthcare system. So remember, in that dot point, we've looked at cardiovascular disease, the nature and extent, the determinants, and the groups at risk. Now it's your job to do that for cancer and one other condition. Okay, let's have a look at growing and aging population. So let's firstly look at the concept of healthy aging. What is this? Well, look, Australia's population is growing and aging, as we know, due to decreased birth rate and increasing life expectancy and increased prevalence of chronic diseases. So elderly are more susceptible, and there's obviously then got that is then obviously going to lead to an increased demand for health services. So what we are saying is that the population is growing and it's an aging population. Elderly people are more likely to have chronic diseases, hence that's going to result in a greater need of health services. It is a process, so healthy aging is a process that includes behaviors and choices that positively affect risk and they reduce risk factors for chronic disease. So, for instance, economic growth. So, for economic growth, you want to stay in the workforce longer. Decrease that will lead to a decreased strain on the health services by the elderly. Then we are able to train young entrants to workforce and able to volunteer and take care of others. Okay, now let's have a look at this specific chart, and that tells us that compares the ages of males and females percentages in 2010. So it's telling us what the population looked like in 2010, and it's comparing us and it's comparing what that would look like to estimated in 2050. So we've got in 2010, you can see the white hair. Oh, what did I do? Sorry. The white hair, we can see that it sort of forms like the white. It's a bit hard to explain this way with like my mouse because even I can barely see my mouse, but I hope you can just try to like keep an eye on my mouse, okay? So you can see that in 2010, we obviously have a lot of a growing middle-aged population, but it sort of remains constant here. But then, as we progress to the predicted population for 2050, you can see that like there's a stark difference between the younger populations, like you don't have as many young kids, and it's starting to increase over here where we've got more middle age and definitely more elderly people. So like it's inversing. So like in 2010 we have more, so like think of like a pot shape, right? So it's again it's hard to I don't know if there's like a laser thingy here. I've used that in Google Slides, but I can't seem to find it here. But again, try to stick to my mouse here. So you can see that, it's sort of like more bell shaped here, like it's going down, but then in 2050, you've got like less people here in the younger ages, and it sort of starts to grow like as you go up. So that tells us that in 2050 we're going to have we're going to have a greater aging population, and that is going to have effects on the healthcare system. Okay, I've got some good questions coming through. Keep them coming. All right, we're going to have a break soon, so stick with me here. Now, demands for health services and incremental effects. So we look at growing and aging population. So growing and aging population leads to increased population with chronic diseases, and that is of course going to have an increased demand on the healthcare system. Think of that not only in terms of treatment, but also in terms of like, needing assistance, needing like housing, needing also like hospital beds and stuff. So not just the treatment itself, but also like the added effects of that. There's, like I said, increased living in aged care. So increased demand for facilities and aged care facilities that will lead to an increased demand of aged care workers, of volunteers. So that requires more workforce training and recruitment in these areas. Overall, this leads to higher costs to the healthcare system, as well as risks demanding more as well as risks demanding more services than Australia can currently provide for. So, availability of carers and volunteers. Now, a carer is a person providing informal assistance, so usually a family member or a friend. Sometimes it can be formal, they can be hired and paid. So there are carers that are provided by the government, so carers NSW. There's of course family members and friends, and also carers in nursing homes. Volunteers are members of the community who offer their services to those who need it. This is unpaid. So think of Anglicare, think of Nursing on Wheels and Alzheimer's Australia. There is a greater demand for both these roles, and availability is not where it needs to be. You would notice that the volunteer workforce is constituted of elderly people, like middle-aged to elderly people. You don't have as many young people in it, which means that once those elderly people are not able to work anymore, there's going to be a reduction in the workforce, with obviously not as many people trained left and not many people left, which means that we need more younger people actually volunteering in the workforce to actually provide for our aging population, and that obviously is something to think about from a healthcare perspective too. Now, let's have a look at healthcare in Australia. So we're looking at range and types of health facilities and services, the responsibility for health facilities and services, equity of access to health facilities and services, healthcare expenditure versus expenditure on early intervention and prevention, impact of emerging new treatments and technologies on healthcare, and cost and access and health insurance. So here, what you have to do is once we go through this, you kind of have to think about, evaluate the healthcare in Australia by investigating issues of access and adequacy in relation to social justice principles. So we are exploring questions of, how equitable is the access and support for all sections of the community? How much responsibility should the community assume for individual health problems? Again, this is about consolidating everything that we've gone through here. You also need to describe the advantages and disadvantages of Medicare and private health insurance, example, costs, choices, and ancillary benefits. Okay, let's have a look. So range in types of facilities. So hospitals, we have both public and private hospitals in Australia. Medicare covers the cost of public hospitals. So if you have, touch wood, ever have to go to a hospital, and you've got Medicare, you're covered, right? Making them more, which makes hospitals more accessible to socioeconomically disadvantaged people, though private hospitals require either full payment by the patient or combined payment using a private health insurer. So we'll talk a bit about why there is that divide between public and private health hospitals, and what that means. But let's have a look at primary care. So GPs, nurses, dental. These are the frontline first point of access of healthcare where referrals are made. Medicare again covers the bulk of the cost, with many GPs choosing to add additional fees on the top of that provided by the government, though there are still some who bulk bill. So there is no extra cost to you. You can still, pop into your your medical center, and if they bulk bill, you don't have to pay anything out of pocket. It's all done by Medicare. Next, we've got obviously public. So we've got like screenings and immunizations. We also have specialized services like mental, reproductive, skin, nursing homes. And we have pharmaceuticals benefit schemes. So we've talked about Medicare, and we would all be quite, like most of us will know Medicare really well, but there's also pharmaceutical benefit schemes, so which provides partial payments for many medications with set amounts being paid by the patient. So you are getting subsidies on medication. This is obviously quite important in terms of like the elderly people have access to it. You need to have certain like you need to have certain needs, like those like pensioners, concession card holders, and war veterans. They are provided with the extra funding because of obviously various reasons, but the fact that they need them. So you are like given PBS, if you show that there is a need for it, and if you sort of like tick certain categories in boxes. So it's again not for everyone, unlike Medicare, but it is quite important in sort of like from equity perspective, because it is directed towards people who need it most, and it gives them partial payments, it gives them subsidies on their many medications. So like for instance, elderly people, they have they have to take regular medication, and buying that regular medication is of course expensive, so they get those subsidies on it. Okay, now who is responsible? So obviously the federal government, they are funding through taxation national health programs such as Medicare and the pharmaceutical benefit schemes and research. So all of these programs are basically paid by us. If you're paying tax, you're paying for it, and all of these programs are funded through tax. Then we've got states, so the provision of health public systems, the development of health promotion activities like overseeing immunization, regulation, monitoring. And finally, we've got the local governments who are responsible for the implementation of health promotion activities like immunizations, for instance, immunizations in community centers, or sporting competitions in community centers, and community like fields. They're responsible for community hygienes like garbage and everything. That's garbage collection is the responsibility of your local government, and waste removal as well. So if you've got new couches, you put your old one out, the local government's responsible for clearing them off. Now, looking at health services for you, me, and everyone. This notion of equitable health services that are accessible by everyone. We are very lucky to have like a centrally funded Medicare in Australia, unlike other places, but here it's achieved by Medicare, by PBS, and health promotion initiatives, and that allows all Australians basic level of healthcare. It's diverse and it's for everyone. However, of course, there are barriers to equity. Firstly, there's cost, right? Like there are out-of-pocket costs that are not covered. For instance, if you use an ambulance to get to the hospital, your treatment in hospital, if you've got a Medicare, will be covered, but ambulances aren't covered by Medicare, so you have to pay for that. There are long waiting periods due to decreased availability of health workers and increased demand of health services. So the waiting periods, if and it's been in the news quite a bit, especially in the aftermath of COVID, where the waits in hospitals have been quite long, especially for surgeries and stuff. Like knee surgeries and all of your all of these surgeries that were not considered as important during COVID, so they were held off, and now there's a long waiting line, and people are waiting to have access to that. Then we've got language, religion, culture, and geographic location. They hinder equitable access, and they also hinder TV access to promotion initiatives. So promotion initiatives that are televised, that are promoted through TV, people for instance who don't who may not speak English won't be able to understand it or take advantage of it. Similarly, with those who may not be able to access TV in a certain location won't be aware of it. So some specialists such as physio, chiro, dentists, they are not covered under public healthcare. So you would, if you've ever gone to the dentist, well, for kids, there is like a certain cap that is paid by Medicare. So like you get like a certain fixed amount every year if you're under 18 that goes towards your dental for dental services, but after that you have to pay for it out of pocket. It's not covered by Medicare after you become an adult. So there is obviously inequity of access due to those costs. Also there's the difference between public and private hospitals, right? So private hospitals, they don't have any waiting time, right? So that is why private hospitals are a a good choice versus public hospitals, especially when it comes to surgeries, especially when it comes to those services, simply because there are no waiting room, there's no waiting time. You get the choice of room and the choice of doctor as well. With public health system, you don't get your choice of doctor or your choice of room, and there is a long waiting list as well. So to overcome this, Medicare, local after hours walk-in clinics, and there's also supporting mobile GPs. Okay, so now let's have a look at the money spent on healthcare and health promotion. So remember, prevention is cheaper than cure, right? And it's more effective than cure, because it targets risk factors and behaviors by promoting health rather than treating with expensive technologies, procedures, and medications. So prevention targets a wide range of people, whereas treatment focuses on the one person. Um, Again, it's about sort of thinking at this not only from a financial perspective, but also from a more personal and not personal, I guess, from a more humanitarian perspective, that you want people, you want to prevent diseases rather than, cure them. You don't want people to suffer. You don't want people to actually go through the whole process, right? So that's why we think of it both from a financial and humanitarian perspective. Um, well, generally people think about it from a financial perspective, but you can think about it from a humanitarian perspective. Prevention targets obviously a wide range of people, whereas again treatment focuses on one person. Um, However, health promotion does not take immediate effect. That's the thing about it. Right? You don't sort of see instantaneous effect, like if you've got like you've implemented no smoking zones, you won't see the smoking rates decline the next day. Like people just go, yep, I'm not allowed to smoke in here. I'm gonna quit smoking forever. We don't see that, but over time we see the impact that that has had. So, like I said, it does not take immediate effect. It does not take immediate effect. It has long-term impact. Hence, there is hesitation to relocate those funds. Because with treatment, you can treat it. You can sort of treat it immediately once you've got all the resources for it and it's done. But with prevention, because it takes time, think of it from a government perspective. Like, governments can say they've treated these many people, and they can say that, I've put this much money towards health promotion. But if by the end of their, by the end of their term, if they don't have any statistics to say, okay, actually this health promotion led to this much prevention, they are going to think that it's probably better to put money towards treatment and say, okay, we discovered this new technology, versus, we put this much money in educational programs to promote awareness for smoking, but you won't see immediate effects for it. So from that perspective, we do sometimes see that hesitancy for governments to relocate their funds from healthcare towards health promotion. Think of tobacco initiatives when you think of this. Think of the tax increases in policies, versus lung transplant. Like, you guys have got initiatives in place. I'm going to increase tax and policies. But again, you won't see the number of smokers decline the next day. It's going to take time. Versus you can say, this is how many, lung transplants that were done. This is the technology we've got now. That, obviously is more tangible than the effects of the health promotion immediately. But over time, let's say 10 years, 15 years, you see the decline. You see the effect of health promotion. Again, if you've got any questions about this, please ask. I'm more than happy to answer any content related questions too, but I've seen some really good questions sort of come in terms of like responses and stuff, so we'll go through that very shortly. Now, new health technologies and their impact. So new health technologies, technological innovation has obviously made it possible for new health technologies to come through, and they improve early detection. They also help in prevention, and thus improve life expectancy and quality of life. So advances in treatments, it leads to advances in treatments and reduces recovery time, and they're also less invasive. Think of like laser surgery for eyesight or knee hole surgery. Um, However, they are expensive. They do increase the healthcare expenditure, and there are long-term and the long-term effects are unknown. So examples are MRI, vaccinations, keyhole surgery, lasers, and screenings. Now, the ultimate showdown. Let's have a look at the advantages and disadvantages of Medicare and private health insurance. So, advantages. So Medicare firstly offers broad range of high quality healthcare. You are able to choose the GP you want to go to. It is affordable. It is subsidized or bulk billed. It's also equitable because all people have access to it. All citizens have and residents have access to Medicare. The disadvantages, however, are that some important services only partially covered or they're not covered at all. Again, think of like physio and chiro, like you need, for instance, physio, if you're physios, chiropractors, also your dentist, like it's not covered. There are waiting lists, huge waiting lists, and there are also limitations of choices due to availability of covered services. Private health insurance. Now, private health insurance is quite interesting because you get rebates by government. That's the first one. Like a lot of people have private health insurance, because rebates are given by the government, and there are also and that includes like tax benefits and stuff. Especially if you are making over a certain like tax line, like you get certain benefits from having private healthcare insurance. So that's why a lot of people would have it more than the services. It's about the rebates. But private health insurance, they give us access to ancillary benefits like physio, dentist, optical, not those that are not covered by Medicare. And with optical, we think of like making your glasses and stuff. That's not covered by Medicare. Getting an eye test, that is I'm pretty sure that is covered by Medicare, but getting new glasses, getting lenses and stuff, that is not covered under Medicare. But if you've got private health insurance with that cover, they will pay part of it, part of the money for your glasses, for example. Superior comfort in surgery and wards. You have the choice of your surgeon. That's quite important, and that's why a lot of people who need that treatment, who need those elective surgeries, they'll opt for it because they have the choice of their surgeon. But obviously with elective surgeries, they also have no waiting list. That's a huge one too. Elective surgeries with smaller waiting lists in comparison to public hospitals. Again, we spoke about how COVID has delayed elective surgeries, and therefore people are waiting in the line a lot longer. There is, of course, the choice of public or private hospital care, and rebates are given by governments. Now, the disadvantages here are that it's costly. Premium needs to be paid regardless of the level of use. So you may never have to use it, but you're paying premium every month or whenever, every fortnight, based on what your cover is. And there are still out-of-pocket expenses. You're still paying out-of-pocket expenses, but what we're doing is that a part of that is paid by the private health insurance. So for instance, if you want your glasses made, you may still have to pay again, kind of speaking from experience here, you may still have to pay based on what your cover is, you may still have to pay a bit, but they cover quite a bit of it. I did see a question come up in terms of what is elective surgery. So elective surgery is your surgeries, like knee surgeries and stuff, which are elective surgeries, like transplants and stuff. That's elective surgery. And we saw in COVID time how there was they were sort of postponed. Elective surgeries were closed because they were not considered as of priority at the time as COVID. So they are your elective surgeries that are not life-threatening in that sense, where during COVID they were postponed, but now after COVID we see that people need those specific surgeries and transplants and stuff, but because of that huge delay, there are longer waiting lines now. Hopefully that